season 3 of the Strength and Chiro podcast. We've had a fantastic season so far. We've had Kelly Starrett, we've had Aaron from Squat U, we've had Dr. Andrew Locke. You know, it's very fitting that we are very, very privileged to have Ben with us. I put it on social media yesterday, but you have a fantastic mind when it comes to rehab. Not only that, but as I was doing a little bit of research on you, I learned a whole new side of you in terms of you as a coach, you as an athlete, you as a strength coach. I know you through Dr. Locke. Dr. Locke tells me that you are the only person on this earth that he refers patients to apart from myself. So international clients go to me and Melbourne clients go to you. So I was like, he must be good. So welcome to the podcast, Ben.
Thank you. Thank you very much for having me too. We've tried to tee this up for a little while, so it's great to be on.
We have. It's been maybe 6 months or more, but it's been worth it. For those that may have missed our last episode, Luke is now a co-host on the podcast. So Dr. Luke Gashard, we also call him Luke Gashard, one word. So welcome to the podcast, Luke.
Cheers, bro. It's good to be back, number 2.
And of course, Dr. Stephen Redmond. Some pronounce it Redmond. I say Redmond. Welcome to your own podcast, Dr. Stephen.
Thank you so much.
Can we have a wellness check on your dog?
He is right behind me.
Recently, I heard you had some commotion happening in your neighborhood. Can you confirm that you're safe?
I am indeed safe.
It's rough out there in the States, isn't it? So, poor lad. We'll get on to it with Ben. Thank you, Ben, for making time. I know trying to get all 4 of us on one schedule was relatively difficult. Not quite as difficult as the time we had 9 time zones with 9 different people, but nonetheless, it was still hard. And we have quite a bit of stuff to get into, so we'll go ahead and get right into it. So, Ben, in the past have read out intros for guests, and I'll tell you what, there's a few times where either the guest hasn't updated their own page, like with Kelly Starrett, I pulled it from his page, and then immediately after I introed him, he's like, that's old, or when I did it with Dr. Locke, and Locke doesn't really have many intros on the web, so I did a lot of research, and then once I finished, he looked into the camera and he was like, yeah, you missed a lot of stuff. I was like, oh my gosh, okay. So I think it's probably best just for you to give our listeners a little bit of an idea of who you are, what you do, and kind of why you're here.
So Ben Lustig, obviously, physiotherapist. Previously, I had a clinical degree in myotherapy, so that was finished in 2012. I opened CrossFit Moreland in 2013, so throughout my first degree, I was just saving rather than drinking and partying like the rest of the cohort. I opened CrossFit Moreland in 2013. That business actually got sold partway through last year. So I've moved exclusively into physiotherapy, having done the Masters in Physiotherapy Practice through La Trobe University. I've been a clinician as a physiotherapist for 5 odd years now. Throughout the time, even when I'd finished in 2012, I was always gearing towards specializing in low back pain or spinal management. That came about through my own spinal issues. So I herniated 3 discs in my back, T12, L1, L4-5, and L5-S1, all in one go during a heavy deadlift. Last lift of the day, as it always is, fatigued, pressure, wanting to perform. That occurred in 2009. So it gave me a really key appreciation for how severe low back pain can be, and what it takes to actually get out of that and live a pain-free life again. That's probably a abbreviated version of everything that's happened in all of that time. I've been lucky enough to present in 2 international conferences, Spine Week and the 11th International Conference on Low Back and Pelvic Girdle Pain.
Nice. No, you did well. The cool thing about your career is that you kind of started out, like you said, you were a coach, you had CrossFit. Okay, so with the whole myo thing, we don't have myos as far as I can tell, maybe a few in New Zealand. It's not really like an option, so to speak. Do you have them in the States, Stephen? Myos? No, they're not very popular. So just real briefly, could you give us a rundown? What is a myo?
That's a great question. Essentially, what I'll do is I'll highlight, so there's diploma level, which is sort of 2 years or thereabouts, and then there's degree level, which at the time that I did it was 4 years and is now 3. So there's a real difference in relation to the skill set that you come out with. What I came out with was more of the clinical assessment skills, whereas I think in the diploma level, it's not so heavily emphasized. There's a lot of emphasis on sort of passive interventions, muscle techniques, muscle energy techniques, those sort of things. Dry needling is incredibly extensive. Like if you want to go to somebody who's really good, you would absolutely choose myo, in my opinion. That's sort of the heart of it. They still do exercise prescription, training modification, those sort of elements as well. In some ways, it can be a little bit of a dulled down version of physiotherapy in a lot of ways. And that's not to detract or take away from what they do in any way, shape, or form. For me, physiotherapy, in my opinion, was a progression and the next level up. And it did give me an enhanced clinical reasoning skills, an understanding and appreciation for research. And I also think it opens a lot more doors. There is a hierarchy, whether or not we want to admit that within our industry. There is a hierarchy to things, and it does help open further doors and sort of progress your career.
Yeah, absolutely. There certainly is. And when it comes, I think, to healthcare, there should be as well, right? You absolutely need to have the appropriate accreditation, certification, education when it comes down to these things. And I think when it comes to the biggest difference, right, between what could be these professions and then physiotherapy or chiro or osteos is obviously what they're able to do when it comes to diagnosis. And obviously as a physio, you have much larger scope of what you're able to do. And so for some people, it's the right fit. For others, there isn't. I know Locke will often say it's the profession or not the profession. That's true for some. We were just talking about Joel Proskowitz even prior to hitting record. One of the most phenomenal rehab guys on the planet and technically a personal trainer. It just blows my mind. It blows my mind. There are always outliers, but no, that makes complete sense. So thanks for explaining that. We've got a few questions. Obviously, we've been chatting about this podcast for a while. There's a few things that we want to touch on. You've done some really interesting research recently. Obviously, you told us a little bit about yourself, which involved CrossFit. I remember probably the first time I ever heard of you was when you were asking people to participate in your research. And I remember going in the comment sections and being like, this is really interesting because I was doing similar research at the time. So the research is done and you've presented that research since. So I would love to know a little bit more about that research. What was the central question that brought you to the point where you wanted to step out of the clinical realm for a second and do research?
First and foremost, obviously running a CrossFit affiliate previously for over 10 years, you build up a lot of anecdotal evidence on injuries and what's more prevalent, what's less prevalent in particular regions of the body. Couple that with my interest in low back pain, and I saw there was a glaring gap within the literature. So there is literature on prevalence rates for injuries in different regions as related to CrossFit, but there wasn't a low back specific one. And for the ones that had been done that did include the low back, it was incredibly generalized. It's sort of like superficial. You don't get to skin deep, so to speak. And so I wanted to go into a lot of detail in understanding what it is that people think are driving that particular issue in that particular region. What do they think is causative behind that? What are practitioners doing about it? What sort of severity and recovery rates do we have? And so on and so forth. So that's why, we went down that path. And then I had a fellow colleague at the time who was a fresh graduate, and we both just wanted to get a hand stuck into the research side of things. We did a survey it was online and then also utilized CrossFit affiliates. So we emailed them directly and asked whether or not they want to participate in relation to the survey.
And that is just in Australia?
That was just Australia. Yep. They needed to be an Australian resident.
And so what was the central question and what were your central findings with that?
Yeah. So essentially we wanted to know what sort of prevalence rates of low back pain in a CrossFit population. What was the attribution or percentage ascribed to a CrossFit related low back pain episode or injury? So how often does that typically occur? We had over 400 responses, which sufficiently powered our study for generalized results to the wider population or Australian population CrossFit group, which was great. CrossFit is such a community-based training regime and business that most people understand that you're trying to get more information for the right reasons, particularly if you're an affiliated owner. So it's fantastic just to see how many responses and how widely distributed it was. We got our responses relatively quickly. We didn't have to push that hard for it. So it was great. Now, the results of which, from those respondents, essentially 70% of respondents indicated that they had a CrossFit-related low back pain episode or injury. So it's a high response. It's a high prevalence rate. From that, we had different questions as related to different modalities found within CrossFit. So the weightlifting or resistance component, cardio component, gymnastics component, 3 main modalities found within CrossFit. And we subcategorized those into individual movements. And so we wanted people to ascribe what they thought was causative behind their back pain episode as related to CrossFit. And so what we found from that is that 75% of those 70% CrossFit related low back pain episodes was ascribed to weightlifting. And then if you look at the breakdown on individual movements, 57% of those attributed their back pain episode to the deadlift and 19% ascribed it to the back squat. So it's overwhelmingly ascribed to the deadlift. Now, whether or not that's accurate, of course, is debatable. And we're not saying that that's absolutely the case. We're saying this is what respondents indicated to us.
I suppose for those listening, it is very common for people to dispute findings of a survey and obviously how well powered it is, how many participants there are in the survey, and most importantly, the questions you're asking, because the comprehension of the participant is extremely important to the answers that you're going to get. But I think a great way to look at it and explain it is that survey-based research is extremely important because it's starting a journey to somewhere where you're going to get even more answers. So it's a stepping stone. And so if you're somebody that is quick to judge or dismiss survey-based research, I would say that's certainly an error in judgment. It can be extremely valuable, especially epidemiological research. So in this situation, many people have this idea that CrossFit is dangerous. And I know there's other research that shows that it's no more dangerous than other sports, etc., etc. When it comes down to your findings, when people are reporting the deadlift, do you feel that is due to one primary or main factor, such as technique, such as load, such as lack of potential coaching, or do you feel like it's many factors contributing? And how would you reconcile that in your own opinion?
Absolutely. So let's go to the questionnaires results or the surveys results and the studies results. We asked participants that, like, in relation to the deadlift, okay, well then what do you attribute as causative behind that along with that lift? And some of the top responses were fatigue, volume, loading, and technique breakdown. So those were sort of the top four responses in relation to it. That already indicates multifactorial elements to it. And in my opinion, it is always multifactorial. And even in somebody who has an acute onset from a deadlift, like let's say we can absolutely track back their onset to a deadlift, usually getting to that point where that was the actual onset of pain, there's a whole bunch of cofactors related to that have led to that being the straw that broke the camel's back, pun intended.
I suppose the variables certainly account for that. It makes sense. In terms of the findings, though, for you, how has that research or those findings and how you have interpreted it impacted your clinical side of how you do things? How has that impacted your clinical rationale when it comes to lower back diagnosis and treatment?
First and foremost, it's informative. So it can give you talking points and education points with patients in front of you. Even if you're trying to just highlight to a particular patient that they're absolutely not alone in having a CrossFit-related low back pain episode, that can be incredibly empowering for the patient in knowing that, okay, it's not just them. This isn't a personal thing whatsoever. This actually is fairly common, the severity of which is incredibly different depending on the person. And our research would show exactly that. So I think it's an educational point, first and foremost. Secondly, it absolutely stacks up with my anecdotal experience. So I would say that a hinge pattern movement, and particularly the deadlift, is one of the most common things that I would see in a CrossFit population as being related to an episode that has occurred. I'm not saying every episode at all. And I'm also not saying even in relation to relapses or reoccurrences that have occurred. It's not always ascribed to that lift whatsoever. But there is a high majority that it typically is. So it informed my clinical practice that anecdotally, and then what we're seeing from a larger scale study, are actually correlating quite well. The other element that, because we also had the other modalities, so gymnastics and cardio, and the responses there, so if we looked at the cardio side of things, rowing had one of the highest prevalence rates, incredibly low, by the way, but it had one of the highest prevalence rates for a CrossFit-related low back pain episode. And that absolutely stacks up with rowing literature, and it stacks up with my anecdotal experience of if someone has had an episode of CrossFit-related low back pain, being on a row is more common than some of the other modalities that you could utilize. When we go to the gymnastic side of things, handstand push-ups, that was one of the most prevalent gymnastics movements that we would see a CrossFit-related low back pain episode in, which is again, it's not outside of my experience as well, along with burpees as well. It helped me to go, hey, this is probably not just my experience, but it's probably other clinicians and other athletes and those who are participating in CrossFit, it's their experience too.
Yeah, lucky I don't do burpees then. No, of course. Like you said, the rowing thing's very consistent with the literature, and then obviously, recently we had the Franklin paper that talked about the GAG increase, and there was a lot of back and forth online about that, whether or not that is an adaptation, a positive adaptation, or whatnot. So I'm going to bring it to a point, because I know a lot of people that are listening, this is really what they want to know, and this is what I want to know based on your experience, your expertise, your clinical understanding, all of that stuff. When the hell does technique matter then? When does it matter? How does it matter? Why does it matter? I'm sure that answer is going to be highly variable, but I would love to know your thoughts. When does it matter?
Firstly, huge question. My initial response is that it's incredibly varied and it's incredibly dependent on the individual.
Yep.
It's incredibly dependent on the context, which is what they're doing or what the goal of what they're doing may be. And so therein, it's actually very hard to generalize an answer, because if I take two different extremes, if I take somebody who's just going to pick up their shopping bags, I absolutely couldn't care less, depending on their injury history or what they're currently contending with. There's still a range of factors within that. I may not care less, but for the sports person, I may care a hell of a lot more. I might actually bring up something that came up with a question, just to kind of circle back to the deadlift component for a moment. So this came up in one of the conferences I presented at, was why do you think the deadlift is so prevalent with injury as compared to the squat, which had the 19% as compared to 57%, right?
Yep.
And in my opinion, if we just look at the ease of entry and skill for each respective lift, it's incredibly hard to lift a back squat really, really poorly with moderate to heavy load. Like, what's going to happen if you're completely and utterly out of position? Well, you're just not going to stand up, or you're going to fall backwards, or the weight's going to push you, et cetera, et cetera, et cetera. So the inherent skill of the movement in a squat is harder if you're talking about the weight variant, not body weight, whatever, doesn't matter. If you go to the deadlift, anyone can pick up something however they want. You don't absolutely have to adhere to a neutral spinal position. You can lift that weight in a full rounded Jefferson curl style if you choose to do so. And so my thought process behind why the deadlift is more commonly seen as an injury is not necessarily the deadlift itself, but it's the nature of the ease of entry into being able to do that movement. Anyone could do it, and anyone can do it in any way, shape, or form they absolutely want to, if they choose to do it that way, regardless of coaching expertise, regardless of their expertise, and so on and so forth. And I think that's an issue. I think that's part of the reason, not the whole reason at all, because it is absolutely multifactorial. But I think that's part of the reason why we see high injury rates in that particular movement. It is easier to go heavy on that particular movement because you can lift it in so many different ways, shapes, and forms. And at certain points in time, that's fine. And in other points in time, it's not. And I'll lead into one key variable, and that's transferability, right? So if you want to lift a deadlift, so a hinge pattern movement in any way, shape, or form, what's the transferability of doing it in that way to other skills? And I would question whether or not it's valuable doing it in any way, shape, or form. So take a bound in plyometrics or take acceleration positions in running. They're not done in like a full rounded position for the spine. They're done in a more neutral so you can get power and force production out of the hips. So the transferability of a hinge pattern done in that particular way, i.e. whatever, actually can impact the transferability to other movements or skill acquisition in other areas. And that's only one point that I see, well, what's the benefit in doing it in any way, shape, or form? Counter the argument to a degree of lift however you want, which in certain times is completely fine. I have no issue with that whatsoever, given the context and the patient. But try and counter it with what's the actual purpose and how can this help me get to other things.
Yeah, and when you say people will lift how they want, they do, yeah, right? So people do in many different ways, and so it's interesting your insight on that, especially I suppose around there's a lot of debate around lumbar flexion online. There's a lot of debate around loaded flexion extensions and how that works based on the mechanism of action for a herniated disc or disruption of the disc or any of that stuff. But when it comes back down to it, there's I really like your insight talking about just the variability of how people can move when it comes to a deadlift or a hip hinge. And I suppose the other interesting aspect of it when we're looking at a squat versus a hip hinge variation deadlift, however you want to call it, is the fact that it is a dead lift, as in there's no eccentric prior to the concentric. Whether or not it's effective, I know coaches for decades have worked very, very hard on pulling the slack out of the bar, using various types of upper body musculature to create tension and rigidity and intra-abdominal pressure. And you're doing all of these things because you're almost trying to create some eccentric where there is no eccentric, so that when it's time to lift, it's boom, and you're ready to go. I have always found that very fascinating, and it potentially one of the variables that also can contribute to the highest incidence of what we would see in terms of injury when it comes to some type of hip hinge or deadlift. I do know that Luke has a question for you regarding this CrossFit topic.
Yeah, one that I had is obviously your previous background in CrossFit and whatnot, and I have myself probably the last few years, doing online competitions and things like that, but have recently transferred to more Olympic weightlifting. So I'm currently at weightlifting club within CrossFit Turian in Brisbane. So one of the largest CrossFit gyms there, which is a great gym, by the way, has an amazing space. But one thing that sort of has changed my approach moving into rehab as well is, and I wanted to hear your thoughts on this, is when you have a patient that you're dealing with that you've seen within the CrossFit affiliate, that might be doing a workout or 50 box jumps combined with 50 back squats at 225, all for time or AMRAP. And then they come into your clinic with a certain area or injury that they're dealing with, and you assess them, you look at their movement patterns, and they can't even perform a body weight squat efficiently or at a reasonable level that you would expect. How does your treatment approach and management with them differ with something like that when they're going to be going back to the affiliate or the box where they're training at and carrying on doing a lot of high intensity volume workouts under fatigue and for time? How does that sort of come into play as a clinician for you?
Absolutely. So I'll draw back to the study for a moment. One of the interesting things that we found from our research study was that what were the elements that individual patients were actually self-directing and changing in response to a CrossFit-related low back pain episode. And one of the main things that came out was load reduction, right? And technique modification. So one of the really cool things about the CrossFit population is they do value position, they do value movement. There used to be, competitions on who had the best air squat position. There used to be competitions on, with a dowel, what's the best position with a deadlift or a hinge pattern movement. So inherently, from my anecdotal experience running the affiliate, and then from our research, people do value modifying load and modifying technique if it means that they're engaged and helping in their rehabilitation process. So that particular population group, one of the biggest things that I'll always do is I'll videotape them in their first couple of reps on whatever movement or movements may be irritating them that they primarily want to work on that may or may not be related to the issue that's at hand. And in videotaping them, they value criticism, they value feedback, and they value development, which is a beautiful thing because as soon as you show them, hey, this is what I'm seeing and this is how I think it may be interrelated to the onset of this particular pain response or how it's sensitizing things further, they're going to be like, great, what do we do to fix it? They're immediately on to the next step. You don't have to spend a lot of time. Towards the end of the session, after we've done a few things, made a few modifications, go back to the video retape and then show them the change and note whether or not there's still that sensitization or sensitivity response in relation to that movement or not. And if not, okay, well, how has it changed? To what degree? So great population group to work with as a general comment. And of course you get outliers who are very stubborn and, sort of stuck in their ways of, no, I absolutely have to do it that way. But that's the exception and not the rule. So I find that they're very good with receiving feedback and understanding of what's going on and then what to do about it.
Based on where my lifting platforms are with the barbell club, it's right down the back of the CrossFit gym. So every day that I'm in there, I see the 4 p.m., 5 p.m., 6 p.m. classes coming in. You know, there's probably one coach for every like 40 to 50 people in a class. And it's just interesting because I find like, obviously you've got that real competitive environment within CrossFit affiliate gym. Sometimes it's easy. I'd expect for the patient, it's real easy for a lot of that feedback to go straight out the door when you push yourself into a competitive environment, or you're doing some sort of online competition that week, or you know, you're testing these max lifts and you've got 10, 20 people around you cheering you on, trying to climb your way up the ladder kind of thing. So interesting question.
It's trying to reconcile what you've seen in the gym, what your thoughts are as a coach, what your thoughts are as an athlete. Like for Luke, who's just recently graduated, now he's seeing patients. It's trying to reconcile like what you've seen, what you know, and then how many people were coming in, trying to manage their symptomatology, their provocative movements and how they move. But I think the major concerns that people have with CrossFit is what Luke highlighted, is people doing complicated technical lifts for time where they're going to razz each other up and they're more likely to hurt themselves. That's a discussion where you can talk about technique, fatigue, load management, whether or not there's enough instructors on, whether or not those instructors have the adequate training. I mean, I can talk to Aaron. You know, Aaron's a very well-established weightlifter at a national level, and he's got friends that are in the Olympics and they've done it their whole life. They're at an Olympic level and they'll still tell me that they don't feel like they're pros when it comes to Olympic lifts. Yet we have Jenny from down the road doing it and supersetting it with wall balls and squats. You know, like, so you get the sentiment of that. I'm interested to hear from you, Ben. How do you reconcile those two things now that you're a physio? From what you're saying, your CrossFit gym sounds pretty bloody good. You ran your gym very well, I would assume, right?
Yeah, fairly tight ship was run. So we had key requirements for every single class that was very clearly outlined. So we had a coach, what we termed a coach's checklist. So what do we do in preparation for the class, start, mid, and end of a class, and then what do we do at the end once it's finished? So it's very clearly outlined. Requires a lot of accountability and responsibility, both at my level and then individual coach levels. And for a time where I could be incredibly hands-on and constantly watching nearly every single class, it's really effective. When it gets bigger and or when I'm trying to take my time elsewhere, that's where it becomes more challenging, and you need leaders to step up to basically operate like me. So that's where it becomes a lot harder. But that was our process that we had.
We could talk about CrossFit all day, but you're very well known for your ability and your skill as a clinician when it comes to lower back issues. Like I said, Locke thinks very highly of you. We had Alan on last episode and he went and saw you, right? And shadowed you for some time, and he only had amazing things to say about you. So I want to get some insight into Ben Lustig's mind for our listeners, because people want answers, you know, and the people that listen to our podcast, we get a lot of chiros, we get a lot of physios and osteos too, but we get a lot of new grads, quite a lot of new grads. Like Giles says, you graduated, you're not a complete numpty. And then like Locke says, once you're graduated, then you have to lose your religion. People want answers, people want tools, people feel lost, especially when it comes to lower back. I mean, lower back is just highly variable, very complicated, and the unique thing about it is that there are experts in the field that are almost completely opposed in their opinions. It can seem that is very confusing for people to have like a Peter O'Sullivan and then have Dr. Locke, to have a McGill and then to have a Gregory Lehman, to have people that are good in their fields but completely opposed on certain things confuses people. So I'm hoping today we have somewhat of a guru upon us, and you can give us a little bit of insight.
The first thing I'd say to a new grad is, like, it's not just one way or the other. It can be absolutely both at the same time, or a combination, or any nuance beyond that. And so I think if you understand that there is a lot of complexity and that that's okay, and that it's not, I have to listen to only this person or only that person, it's really just trying to find a balanced approach as related to the person in front of you, not as related to the research that you've looked at, which can be relevant and help guide what you may ask or what you may do as far as the treatment side of things goes. But it could be absolutely 110% completely irrelevant to the person sitting in front of you. That's what you've got to balance. And then you only get that with experience.
Yeah, wisdom.
Stacked experience.
I like it. Okay, so would you be open to taking us through some of the components of your assessment or your approach to lower back disorders?
Absolutely. So ultimately, the main components of your assessment, these are your fundamentals, your basics, and I'm a big believer in having a high standard of application and interpretation of the basics. And I really think that's where new grads go awry. They're looking at the treatment element, or they're looking at all the flashy things that you can do in relation to the treatment side of things for patients, particularly in a low back pain setting. My area of interest and where I get a real kick out of this job is like, how do you arrive at what you want to do, right? So instead of flipping it around and looking at all the fancy things that we can do for a patient, how do I arrive at accurately figuring out what I want to do with them? So in line with that, our assessment, it's tried and true. You've got your subjective, your objective, any special testing. Super straightforward. And special testing could be a referral for imaging. It could be a nerve conduction velocity study. So you may need to lean on other modalities and other specialist fields in order to get a clear picture of what's going on. At the end of that process, you absolutely have to answer one key question. Is this case consistent across all those three areas, or is it inconsistent? And if it isn't consistent, what do I need to do to change that? It's actually really straightforward. Now, if we take the example of the subjective component of your assessment, in my opinion, this is the area that's most poorly done. I, most of the time, have a really strong idea and clear idea of what's going on just based on the subjective. And I would actually argue just based on their body chart. So your subjective provides you with information on potential pathoanatomical sources of nociception. It provides you with the psychosocial elements of their pain experience, how it's impacting their quality of life, what support networks do they have, and so on and so forth, and whether or not there's any negative feedback loops going within that, which absolutely can persist their low back pain. Doesn't mean it's causative, but it can persist and or worsen. So let's do an example of a subjective that's poorly done. And I want to bring into play here red flags, right? Now, we all know about red flags related to suspected serious spinal pathology. And in the literature, it would suggest that in clinical practice, we'll see around 1% to 2% of cases that may have elements of a red flag or red flags, okay? Now, imagine missing that. Imagine missing the red flag and the potential consequence on you as a clinician, your credibility, your practice, any medico-legal concerns, and the patient. What's going to happen to them? Now, because I have a clinic that at this point in time, 90 to 95% of patients that I see are spine related. So neck, upper back, low back. So it's an incredibly high proportion. And so within that, I see a lot more cases that do come up with red flags. It's just the nature of the beast. And the amount of times I've received a referral to have a second opinion, and I'm like stopping my assessment partway through a subjective, and they're immediately going to go see the neurosurgeon. It's happened a fair few times. And in the last 6 months, I've had 5 patients in which that has happened.
Yeah.
That's a high proportion of missed opportunity and potentially serious consequences, particularly if you treat them in a way that could be adverse to whatever the red flag is indicating. So I'll give you a specific case study example of this, obviously without going through the patient's details in too much, not covering too much detail on that front. So this patient was ACDF, so basically a post-operative neck spinal patient. And when they came to me post-operatively, they were a number of weeks. We were going through absolute basics, and they mentioned they're like, just feel like this odd sensation. Like, I can't even describe it. It's not a pain. It's not. And I went into a lot of detail. Is it tingling? Is it numbness? Do you feel weak or anything? He's like, no, I just feel kind of odd from like here down, and it's not happening a lot. And I actually knew this guy from previous, and he was a pretty hyper-vigilant person. Like, he would focus on a lot of little details that would often be completely irrelevant and not related to his actual pain response. So I had that in the back of my mind, but I'm like, but you're post-operative, so I've got to take this seriously. And upon questioning him further, I was like, this sounds like cord signs. And so with that, I did a really, really thorough, even more thorough than what I was going to do, upper and lower limb neurological examination. And sure enough, we had positive Babinski, we had positive clonus responses in relation to this particular patient. And I immediately stopped my examination there. I detailed my findings and I said, go straight back to neurosurgeon. He was in hospital that evening. He had surgery the next day. And what had happened was the level below where he'd had surgery, we already knew that it was herniated, and the decision was made by the surgeon and the patient to operate single level, and if needed in future to go to multi. And that had herniated to a greater extent. It was creating cord compression. The guy can end up with paralysis. So it was so subtle. It's out of all the red flags I've had, it's easily one of the most subtle cord signs I've ever seen.
Wow.
And I'd be hard pressed to ever confidently say that anyone, let alone somebody who's just starting out, would have gone into detail and actually properly assessed that. And the consequence of that on that patient, really serious. So to me, it's subjective, lots of detail, like go into detail in relation to each individual response if you need to. And I do that routinely.
If you missed it, what do you think the progression would have been for him?
Ultimately, you can only speculate. But if he's getting subtle signs, typically I like the term from little things, big things grow. And I think that would have progressed, particularly in that case. And I think the consequences of that could have anything been from, short-term, severe neurological changes to something more permanent.
Yeah, what you're saying about the subjective, it's incredibly important. I know it's a very famous quote saying that 80% of the diagnosis you can get from the history. I always joke about Dr. House because in all of those seasons, I love Dr. House. He's constantly saying when they're belly up and they don't know where else to go, he goes, go back to the history, always go back to the history. But what I really like about what Giles is an osteopath, owner of OMT, he will say, if you're unsure, just refer. Don't be a big man, don't be Dr. House, just refer. And I know there's a lot of people out there that are like, well, no, I'm a physio, I'm a chiro, I'm a doctor, I'm a primary healthcare practitioner. I can see people off the street. I don't need referrals. I'm not a myo, I'm not a trainer, I'm a tier one. And they have this kind of idea. But I think it's really important to be humble in the sense of like, if you're unsure, it's okay to refer. Even if you refer to someone in your field who's maybe more knowledgeable. But at the same time, it's fantastic to once you're in practice, build up a system of people that GPs, neurosurgeons, all across the board, even out of clinical realm, researchers. It's good to have people that you can consult about different things. But what you talked about there that I thought was really interesting is you made a comment about you were weighing up what he was saying compared to what you knew previously about him, right? And that was almost key to your conclusion because you're like, I know and I've established what this guy is like and he's saying this and I know that. So for you, how important is it to really clearly communicate and get to know the patient when it comes to this type of situation? Because so many of these new grads, so many people that are just coming out, they are just bombarded with soap notes. They're just bombarded with information and they're finding it really hard to even know what's up and down, let alone catch any red flags. Do you know? So what would you kind of say to those people?
Yeah, so it really comes back to the same thing, which is really just the basics. And the first point of call when you have a patient, particular spinal patient, in with you is to triage them into three main categories. Are they red flag or suspected serious spinal pathology? Are they a radicular syndrome? Or are they in the non-specific category? And there's a lot of argument on the non-specific category. Understand that it's a triaging system. It's not a diagnosis.
Yeah, good. Yeah, obviously there's a lot of discussion around that and a symptom versus a sign and how obviously non-specific lower back pain can be problematic as a diagnosis, especially when it comes to how you would, determine a treatment on something that's non-specific. Of course, what you said there in terms of the triaging makes complete sense.
So if we go on the flip side and if we take the special testing area and if we take imaging, so let's say you've got a patient in, they've already had imaging, you first look to the scan, you read the scan, you hear the patient for a couple of minutes in relation to their subjective, and you go, okay, well, this is just related to the scan. This happens all the time, right? So a diagnosis happens because of the imaging and not necessarily because of the subjective objective, and the imaging, all three combined. This also happens all the time. So this isn't just the error in the subjective component, it's also an error in the objective assessment. It's both, but it leads the clinician on a path of confirmation bias in relation to the rest of their assessment. If they're going to decide very early on the scan equals the patient's pain response, it's often incredibly detrimental to that patient. And patients make that mistake because they come in and they tell you exactly what's going on in the scan and why their spine is broken. And other clinicians or practitioners make that mistake in thinking that that is what's relevant to the patient's pain. You do a good subjective, most of the time you can rule in or out the possibility of a scan very, very quickly. And that's the element to contend with. I'll give you a patient example of this. Circling back, my process is that I look at scans second. So I'll go through my entire assessment. I'll literally ask them, have you had scans? Oftentimes I'll ask them, are people in agreement with what's on the scan or not as to what your diagnosis is? A lot of the time they will say yes. Of course, I have changes to that depending on the person, but a lot of the time they will say yes. But I'll go through my entire assessment process. I'll verbally go through what I think is going on with the patient and why. And then I'll ask them, does this correlate with what your scan says? Most of the time at this point, I will be able to identify whether or not the scan is relevant from all of that being done one step at a time. But the scan is absolutely done at the absolute last point of the assessment because I don't want it to bias what I ask and what I do. And I also want to leave the patient in a position of confidence that if I'm thinking something else, well, I haven't read their imaging prior, so I'm not being biased by that whatsoever. They already know that. And it can actually give a lot of credibility to what I may be proffering instead. So if there is changes, perhaps it's disc herniation, perhaps it's stenosis, whatever it may be on the image, it can actually help quell concerns as to whether or not it's relevant for a particular patient. It can help with buy-in, it can reduce fear in that particular patient, and ultimately it helps spearhead your rehab outcomes straight away. One of the great examples of this was a patient. I did this in reverse. It's very rare that I do this, but I had to because this patient was like 8, 9, 10 out of 10 pain. They were literally being rushed into my clinic in the next 30 minutes. They had imaging, and I needed to determine, is this person for me or for hospital, pretty much. It was as clear cut as that. So I went in and I reviewed their imaging, and their imaging showed low lumbar bilateral nerve root compression to the S1 nerve, right? And so I'm thinking, okay, well, this is going to be a high-level neural case. They come into clinic, and the region of pain that they're indicating is either side of the spine, sort of mid-thoracic region all the way through lumbar, zero referral, nothing glute, no posterior leg, no foot, no neurological changes, sensory, motor, reflex, nothing. And I just said straight out, I'm like, your scan is completely irrelevant to this case. Now, I won't go into detail on what was going on, but fundamentally, sometimes scans are relevant, sometimes they're not. I highly encourage everyone to look at all those elements second so you don't bias what it is that you ask and what it is that you do in order to establish what you think is going on.
Yeah, it can sometimes, like you said, you go down the rabbit hole of a confirmation bias. And I've had clients before where the scan is saying one thing, but I'm actually picking up something else. And so we'll go through and we'll do our rehab, and this is very successful. And it was a different level. Or they've had surgery, done the surgery to the level that's been shown up on the scan, but then it was actually a few levels up or whatever down from that site that they were actually symptomatic. And then this kind of leads into the McGill research on how someone can move dynamically versus what you can see on a scan in terms of the disc, right? A dynamic issue like that may not show up obviously on a scan, especially if it's a superimposed 2D scan like an X-ray. We just had a research paper PubMed published on unethical X-rays, for pretty much reaching a diagnosis when it comes to spinal alignment. And this was directed at chiropractors, but I bring it up because it's very relevant to what you're saying. Within certain parts of the chiropractic profession, mostly the Gonstead, you will draw up lines on the X-ray. You'll go into the booth and you'll actually look at the X-ray, you'll draw lines, end-plate lines, you'll look for what's converging, and then that actually leads you to your diagnosis. It's literally doing the thing that we were saying you probably shouldn't be doing. And then it's very interesting, when we were at school, me and Luke would have lots of headbutting with our professors when they were saying, you've got a posterior left or whatever, you've got this listing, and you're like, yeah, but my findings are showing me something else. You'd have to plead your case to be able to treat where you want to treat, because the mentor is looking at a X-ray, and sometimes the X-rays are taken 4 years ago, and they're still having greater influence upon the diagnosis than the subject or even the other testing that you can do. So it's certainly, what you're talking about is very relevant, some for more subsets of professions than others.
Absolutely. I couldn't agree more. So the other topic that we can cover here is, we understand that prevalence rates and probability are interlinked together. You can get a viewpoint as to a possible diagnosis or diagnoses before asking an incredibly detailed subjective and going through objective testing. So an example of this is linked to age, right? So we know that certain spinal conditions occur at various ages throughout our lifespan. So if we look at spondylolysis, this is a more prevalent issue in our youth population, which is a pars interarticularis issue, typically related to sporting activities, high extension rotation sports, or lots of sport. And in that particular population group, it's common because the spine is still hardening, it's still forming. And so we would typically see more prevalence of that particular issue in a youth population group. And so if I get a 15-year-old who's booking in, well, I'm already sort of leaning towards, what is the possibility that this is present? I'm not going to think of like a stenotic-based case at all. So if we flash forward to our adult years, discogenic, facetogenic, SIJ, they're more prevalent within that particular age category. And then when we go to our elderly, it's more our stenosis-based issues. So even by just knowing somebody's age, that's it. You can take it a step further to gender as well. And knowing the prevalence rates in relation to certain spinal conditions over the lifespan, you can already start getting an inkling into the probability of what you're dealing with before you've asked a single question. So that's one example of using age and the link between prevalence and probability. And the other one that we can utilize here is the distribution of symptoms. So your body chart, right? Now, let's say, for example, you've got a patient who presents with right side low back pain, extending into the right glute, the right posterior thigh, the right outer aspect of the lower limb, extending into the big toe, okay? Let's say that you're suspecting, just to give a little bit more context, that this patient is dealing with a discogenic issue. Well, what are our prevalence rates and their probability of a disc herniation, and at what level and in what direction is that occurring? That's what we're asking here. Before we've asked a single question, just based on their body chart. Now, based on that distribution of body chart, I'm immediately thinking L5 dermatomal distribution. I'm thinking they're in the right L5 nerve root and a potential L5 radiculopathy, okay? So what are our statistics? 80% of disc herniations in the lumbar spine occur at L4-5 and L5-S1. So firstly, I'm looking at those two segments. Secondly, there's a big difference in prevalence rates between far lateral versus central or paracentral disc herniations. So if you look at the bird's eye view of a disc and you look at the location of the herniation being straight at the back, slightly to one side, or all the way off to the side, there's hugely different prevalence rates for that. And they're in probability that that's what's going on. So if we go to the below level, I mean, there's two possible main locations that an L5 nerve root related to a disc can be impinged. If we go to the below level, that would have to be contacting the L5 exiting nerve root at the level of L5-S1. Does that make sense? That would therein have to mean that we're dealing with a far lateral disc herniation. A far lateral disc herniation made up in a foraminal or extraforaminal zone makes up around only 5 to 10% of cases. So there's a very low probability that I'm dealing with a disc herniation at that level. If, however, we go to the L4-5 level, central and paracentral disc herniations make up around 90%, with the overwhelming majority being paracentral in nature, right? A paracentral L4-5 disc herniation can absolutely contact your transitioning L5 nerve.
Yeah.
So I can describe a degree of probability just based on the distribution of symptoms, so the pain distribution based on their body chart, before I've done any other questioning or any other orthopedic testing, to the tune of 80% based on those two regions and 90% in terms of to which direction it's gone to.
Yeah, and to make things worse, there's obviously literature out there now showing that radiculopathy or radicular pain will only follow a dermatomal pattern 16 to 66% of the time, which just throws another spanner in the works.
Sure. There's always, so here's the thing, is there's always going to be research that counters whatever has been said. This is absolutely the norm. What typically occurs in clinic, because we do also get told, dermatomal patterns are very different depending on the person, and that's absolutely accurate. You always have the norm, and then you always have outliers to that. But there is a lot of consistency. If you see a lot of cases, there's a lot of consistency in dermatomal distribution, motor change and reflex changes, all those sort of elements, as in particular spinal nerves. So what knowing prevalence rates does is it gives us a probability of what we're dealing with before we've done almost anything. That's purely just on pain distribution or age alone. And there's so many other ways that you can mix this to give yourself an understanding of what may be going on. You don't need to be confirmation bias after that, but it absolutely helps with getting a viewpoint on what may be going on. If I may, and this is sort of the last point we'll go through, how to use that if you're trying to diagnose a particular structure. Okay, so let's look at structure. We've looked at age, pain distribution. Now let's look at a particular pathoanatomical diagnosis. The more you cluster tests together, the more probability that what you think is going on is accurate. Simple as that. And the more you can eliminate that which is not. It's a true positive or a true negative, essentially. If we were to suspect a discogenic issue, what are some of the tests that we can go through, and what sort of probability can we ascribe that what we think is disc is probably disc? So there's studies on all of this, right? Lumbar spine repeated movement testing with a directional preference has a greater than 80% probability of ruling in a discogenic issue when there is a discogenic issue present. And that's as compared to gold standard, which is a discography. So that's a gold standard medical level diagnostic procedure. Okay. If I layer on top of that the phenomenon of centralization. So centralization is a movement of symptoms from more away from the midline or periphery, more towards the midline, or centralizing, right? Then I increase my probability that I'm dealing with a discogenic issue again. If I add in a positive straight leg raise, so a straight leg raise test that's positive within the first 45 degrees, I increase my probability. And lastly, if I add in a straight leg raise on the contralateral side that's affected, so using the right side as the symptomatic side, I raise my left side and I get a symptom response on my affected side. That's called cross sign. There's a 95 to 97% probability that I'm dealing with a disc herniation at that point. So all I've done is just layer on layer on layer. Do I have a consistent response here? And therein the likelihood that I'm dealing with a potential specific pathoanatomical issue becomes more and more probable. It doesn't mean that it's necessarily gold standard. And there's a big difference between your clinical testing and then your medical level testing, but it massively increases your probability. So that's one way in which you can use probability within your clinic to more accurately and more likely rule in what you think is going on is actually going on.
I mean, it makes a lot of sense. I think a lot of people probably do it quite intuitively as well. And it's really nice to hear it laid out like the way you've laid it out, continuing to kind of build upon a diagnosis or differential diagnosis and the importance of that, especially when it comes down to lower back. I just know so many people find themselves confused and intimidated when it comes to a back issue. You know, somebody walks through the door, and I suppose we're taught one thing in school, and then when you get out into the real world, it feels like so many people present differently than what they're meant to. Even more so in that situation, can you use what you're saying, the probability and prevalence and understanding the person and the demographic and the information around. I mean, that's fantastic, right? It makes complete sense. And we actually touched on a little bit of that when me and Locke did our seminar here in Auckland. And it's so incredibly helpful. It's almost like it gives you that jump start. Even as the person's walking in the door, or even as you look at the chart before the person even comes, it's trying to pick up a greater understanding so that when I'm going through my detailed comprehensive history, I'm going to be asking better questions. But no, that's fantastic, man. We'll finish up there, but thank you very much for your time.
My absolute pleasure. Thank you for inviting me. Hopefully I've given some information that's going to be really valuable to you guys and to your listeners as well.
Absolutely. You certainly have. Once again, appreciate you, Ben. Thank you for your time. Have a great day, have a great weekend, and we'll catch up soon. Stay in touch.
Absolute pleasure.
Thank you so much, Ben.